Good evening and welcome everyone to our information and support session. My name is Kathleen Helgeson and I'm the coordinator of the Patient and Family Resource Center. This is the first information session on chronic lymphocytic leukemia that we've hosted since the fall of 2019 and the first time that it's been offered virtually. I'm very excited about the lineup of presenters that we have here tonight who will be sharing their knowledge and answering your questions about CLL. We are very pleased to offer this webinar with the generous funding support of the Cancer Care Manitoba Foundation. I'd also like to acknowledge that we're meeting from all regions in Manitoba, the traditional land of the Anishinaabe, Cree, Ojibwe, Cree, and Dene people, as well as the homeland of the Métis Nation. It's important for us to foster inclusivity and reconciliation and encourage others to do the same. Before we continue, there are a few basic Zoom features I'd like to explain. You'll notice that as an attendee, your microphone and your video are turned off. If you have a question at any time during the presentation, just click on the Q&A icon at the bottom of your screen and you can type your question. You can also choose to ask that question anonymously by checking the Send Anonymously box before you click on the blue arrow to send. Our moderator, Dr. Yang, will be helping us manage the questions as they come in. If you have a technical concern, you can also type that into the Q&A and I will answer your question privately and try to assist you. I'd like to now introduce our moderator for this evening. Dr. Lin Yang is a blood specialist in CLL. She completed her medical training at McMaster University in Hamilton and her PhD at the University of Toronto. She then returned to her hometown of Winnipeg and is a member of Cancer Care Manitoba. She enjoys family time camping with her husband and her 3 young boys. Welcome, Dr. Yang.
Thank you, Kathleen, and welcome everyone. I am so thrilled that we're able to get together in somewhat less than ideal situation, but still nonetheless get together and share our knowledge of CLL. So the theme for tonight is really putting together a comprehensive review of CLL. So I really hope that you find it educational. As many of you have noticed in your programs, that the first talk is by Dr. James Johnson, who unfortunately last minute could not attend the session. He sends his deepest regrets for this. So I have now the honor of introducing the ABCs of CLL. I do want to give Dr. Johnson the credit for the slides that he has made and lent to me for tonight. So I am now going to share my screen. 1 second. Here we go. And a few more clicks and we're there. Perfect. I do want to introduce Dr. Johnson because he is such an important part of CLL and where we are. So many of you who know him know that he has been a pioneer and instrumental in understanding and studying CLL for quite a while. He has published hundreds of papers in very high impact, high quality journals, and he is well known both nationally and internationally for his work. And he's also well known for just being a really caring physician. So I'm going to do my very best to present in his absence, but I will be missing the elegant Irish accent for those of you who know him. So a very common scenario of how patients get to our clinic is that someone goes for their routine checkup with their family physician, annual checkup or whatnot. And as part of that, a blood count gets done. And then it is noted that one of the type of blood cells called white cells are increased, and specifically a type of white cells called lymphocytes. So when you look at this picture here, what this is blood that's laid out on a glass slide and looked at under the microscope, and we can see what the different cells look like. So lymphocytes are these purplish looking cells, and we'll notice that in CLL, these cells are increased. There are other cells in the blood as well. These are red cells, which are also known as hemoglobin, that carry oxygen. And there are platelets, which are meant to make blood clots when we cut ourselves. So when we see these white cells increase, these lymphocytes, more blood is taken to do some specialized testing to confirm that they have the picture of CLL. And if that is the case, then they're referred to our clinic and seen for this discussion and evaluation. The average age of a person coming to the CLL clinic is 68 in the province of Manitoba. It's twice as common in males as it is in females. When you come to the clinic, you will expect an examination. And what we're looking for are enlarged glands or nodes. And we're looking to see if the spleen is also increased in size. So this is an example of a gland or a lymph node that's under the right armpit. And then this is meant to show an enlarged spleen. It's a bit hard to see, so I've kind of given you a cartoon picture here. The spleen is an organ that's nicely tucked on the left side of the abdomen underneath the ribs. When it becomes enlarged, then it descends down, and then you can start feeling it and measure the size. And why is this so? Well, it's because the cancer cells grow and divide in the glands and in the spleen, in the bone marrow. So when they are expanding, we can then feel it in these organs. You will also notice that we use some terminology when you come to the clinic, and we'll tell you which variant of CLL you have. And so how do we define this? Well, this is the terminology we use. If you have chronic lymphocytic leukemia, which is CLL and it's the most common, you will come with increased or high lymphocytes in the blood. That's how it would likely be diagnosed. When we examine you, we may or may not feel glands or enlarged spleen. There's a similar condition to CLL called SLL, which is less common, about 15% of cases, and this is small lymphocytic lymphoma. Both are very similarly treated and followed. It's just that they slightly vary in how they present. And that's because in SLL, instead of presenting with these lymphocytes in the blood, these people have more of a gland and large spleen picture as initial presentation. And they may in fact have very little or normal lymphocytes in the blood. Commonly though, when this comes to be, they often require a lymph node biopsy or a lymph node to be cut out to be examined under the microscope to show that the cancer cells are in there, and that's how the diagnosis is made. There is a condition called MBL, or monoclonal B-cell lymphocytosis, which is a precursor, a precancerous condition, as we sometimes call it, to SLL and CLL. And as the name suggests, we shouldn't be able to see cancer cells. So in the blood, there should not be increased lymphocytes, and there should be no enlarged glands or spleen. And why is it important to know the definition and to kind of put it into categories? Well, it's because it relates back to the physiology of this condition. So bear with me as I walk through this slide, as it could get a little confusing. So MBL starts with a clone in the blood, but the clone is very, very small and doesn't cause any problems. It doesn't cause enlarged glands. It doesn't cause enlarged spleen. This is actually a fairly common thing that we see. And how do we know it's common? It's because they studied thousands of blood donors that donate, for instance, to Canadian Blood Services or any American centers. And they just surveyed thousands of people. And they found that up to about 10% of people can actually have this if you look for it in their blood. And that number increases as you age. And it's important to know because MBL can progress to CLL or SLL. So to put it in another way, and I hope this doesn't make it confusing, all CLL came from MBL at some point. So there is expansion of these MBL cells in the blood. They grow, they divide to the point where eventually it can be defined as either CLL or SLL. But not all MBL do this though. There's some MBLs that just stay quiet the entire lives and never change. But some MBLs seems to want to expand. And we don't quite know who are these people yet, but it's one of the areas we're actively studying. Also good to know is that about 1 to 2% of MBLs go on to developing CLL or SLL requiring treatment. So that's yet an even smaller proportion of patients of MBL that go on to do that. And for that reason, we follow all people with MBL, CLL, and SLL in our clinic because we'll be monitoring for that progression. There's also a familial CLL, which is about 10% of our cases. And we also are studying how this has come to be. You'll see inheritance pattern or several generations with CLL, and it's more common in the European ancestry. So this is roughly the breakdown. We see the bulk of our patients are CLL, and smaller proportion are SLL and MBL. You also see us use terminology called staging once we have diagnosed you with CLL. And this is a language that physicians talk to other physicians to kind of communicate where is the disease at right now. So to break it down, you could present with rise stage 0, which is where we just see the lymphocytes in the blood, but there's no glands, nothing else we can detect. And this is considered low risk for requiring treatment and progression. Rise stage 1 and 2 is when we start seeing the glands or the nodes enlarged or the spleen enlarged, and this is considered intermediate risk. And rise stage 3 and 4 is when we see a compromise in the red cells and the platelets as a sign that the CLL is expanding in the bone marrow and taking up real estate in there so the other blood cells can no longer function or make proper cells. And this is considered high risk requiring treatment. The majority of our patients, more than 3/4 that we see, are thankfully in the rise 0 and 1 stage, so very early on. And that's because many people get picked up because of a routine blood test through physical exams with your family doctor. And about 50% of patients will go on to progress through the stages, where there are some that will not. So what's the natural history of CLL and SLL? Well, what will happen is that it will gradually expand. And by gradually, we can mean years. So this is considered slow growing or indolent. And when it starts expanding, what it will do is it will go to the bone marrow and start causing the other blood counts to drop. And as a consequence of that, if you become low in hemoglobin or anemic, you start getting tired or breathless when you do activities. The other thing that CLL cells can do is break down the immune barrier. So we have an intact immune system naturally, but CLL cells can weaken that system. So as a result of that, we see infections come through. And I won't talk about too much about that because Irina is going to have a whole talk on that today. But I do want to talk about increased risk of secondary cancers. So what does we mean by that? We mean other non-CLL cancers. So lung cancer, prostate cancer, colon cancer, breast cancer. Dr. Johnson published a very nice paper along with Dr. Banerjee describing the risk. And we estimate that these type of cancers is about 2 times higher in patients with CLL than people who don't have CLL. In particularly skin cancer, which can sometimes be overlooked. Actually, there's a 5-fold increase in risk in patients CLL versus those who don't. So what can skin cancer look like? These are some pictures of actinic keratosis, squamous cell, basal cell, melanoma. And it's always a good idea to have these picked up early on and get it treated rather than waiting too long. The risk factors for developing these skin cancer in addition to CLL is male, age of over 70, and if you had prior chemotherapy. So our general guide is, keep out of the sun, use sun protection with the sunscreens and the hats and the shirts, and get yourself connected with a dermatologist, and we'll help you do that in the clinic and follow the cancer screening guidelines. Shifting gears a little bit, I want to talk about one of the challenges that we face when it comes to management of CLL. And that's because of what I said a little bit earlier, that about up to 50% of our patients can have such an indolent course that their disease just expands so gradually it doesn't require treatment. Meanwhile, there's about 50 to 70% of patients that we see in the clinic that will go on to have treatment. And when we first meet you in the clinic, we have very few things that can help us gauge which camp that you're in. Are you going to be in the camp that just will stay very slow growing? Or are you going to be in the camp that in the next little while you're going to require treatment? So it's very hard to predict right at the beginning when we see you. So everybody undergoes this period of active observation. So I want to talk a little bit about what that means. And why do we do it this way? Well, for a couple of reasons. One, like I said, many people come with very early stage disease, and they're so, the disease is so minimal that it doesn't impact how they live. And people can stay like that and live very well, a very normal life for a long time before the disease can pick up momentum and needing treatment. And so it's hard to justify intervening so much earlier when it doesn't impact your life. And we know that by treating it earlier or more aggressive doesn't mean you'll live longer. And we know that we won't, generally speaking, won't be able to cure the CLL. So we'll never be able to eradicate it completely. And there are side effects of treatment. So if we don't have to intervene and give you that treatment and you can live very well for a long time, there's very little justification for doing that. So then a typical pattern of how we describe CLL over a long time is that your lymphocytes will increase or expand, and then at some point there's a need to treat, and then the treatment will bring the lymphocytes down, and you're considered in remission or with sleepy state or dormant disease that are now back to kind of baseline. And then over time, the disease may pick up pace again and peak, and then we say it's time to treat again. So this is the blood count of of a patient in the clinic that really illustrate this picture. Someone who was diagnosed several years ago and being followed, and over time, lymphocytes pick up and it gets to a point where we think he needs treatment, because for this particular patient, you can see that the hemoglobin or the red cells are dropping, so that now we think there's enough burden of this disease. So treatment is here, and you can see the lymphocytes drop very sharply to very normal levels, and you can stay like that for a very long time, and then eventually the disease may pick up pace again, hemoglobin starts dropping, so now we think we need treatment again. So during this active observation period, when we're gauging the tempo of the disease and looking out for signs of whether you need treatment or not, what you expect is that we will follow you in the clinic for an exam and do the blood work to monitor. We will remind you and help you look out for other things like infections and the cancers, and help with immunity issues if they come up. So the things that you could do for yourself during this period of time is really to stay as healthy as you can possibly be, so that if you do need treatment, you're in a good shape and a good place to do that. So these are general statements, no smoking, limit the alcohol, keep a good weight, keep fit, get your cancer screening done, including your skin checks, and take some vitamin D, which Rania will talk a little bit later. But when do we think that it's time to need treatment? Really, when we think there's a burden of the CLL enough to start causing some problems. One of the things is we look at how quickly the cancer cells are growing, called doubling time. Is it less than 6 months? Or how quickly is your spleen and glands growing? We look at if these are causing you problems, or you're having pain or discomfort from how big the glands are growing. Are you having sweats? Are you having weight loss that you can't explain? We look at your other blood counts like red cells and platelets to see if they're starting to drop and being compromised. And lastly, we look at whether there's an immune problem to your blood counts, which can be seen in a quarter of patients with CLL. So once we decide on your treatment, this is a nice segue to now introduce Dr. Banerjee, who will talk to you about how we integrate prognostic markers and treatment decisions together. So I would like to introduce Dr. Banerjee, who is very well and highly accomplished. She obtained her MD and residency training in internal medicine and hematology at the University of Manitoba. She then completed a postdoctoral fellowship in translational research at the Harvard Cancer Center, the Dana-Farber Cancer Institute, and Broad Institute at MIT. She is a senior scientist at the Cancer Care Manitoba Research Institute, an associate professor at the University of Manitoba, and clinician scientist at Cancer Care Manitoba. She co-leads the CLL clinic and is involved in several clinical trials and population-based treatment studies. As co-chair of the CLL research program, she manages a multidisciplinary research team in clinical, fundamental, and translational research. Her own laboratory is evaluating mitochondrial bioenergetics and function as a measure of cancer cell metabolism. So welcome, Dr. Banerjee.
Thank you, Lynn, for that very kind introduction. I am just sharing my screen. All right. So thank you very much to everybody joining us this evening. I have to say we are very glad that you were able to join us, and I have to say that we're very proud of the turnout from tonight as well. So thank you again. So I hope during this talk, what I'll be able to share with you is what information will be essential in the partnership that takes place between you and your treating physician in the decision making that is required when somebody needs treatment. And this is a very complex area, but I do want to reassure you that there is something for everyone, because treatment is really designed by taking you as the individual into consideration. And I think this is the true era of what I would call personalized therapy. So I think it is really important to keep in mind who our population is. It is a chronic condition that may require long-term treatment. And the reason I think this is important is that we have to think of the age span in which someone is diagnosed. About 90% of patients are diagnosed with CLL or SLL are at least 55 years old. And I know Lynn pointed out that in our clinic, the average age is about 68. But if we take the population of the world as a whole, the average age is about 72. But given the wide range of ages that we see across our clinics, I think it's important to note that treatment may be something that people see on an ongoing basis. So what are the factors that we have to take into consideration when we think about treatments? And one of the things we have to be very well aware of as physicians is what other medical conditions do patients have. And that's really important because certain medications may not be good with certain underlying conditions. So if you have active heart problems or uncontrolled blood pressure issues, these are things that might impact the selection of the treatment. So when we first meet you, we do a great job of going into your medical history, but it can be 10 years from the time we first met you that you will need treatment. So these are things that we would like to revisit at the time of treatment. And so we might ask you a lot more probing questions at that time, because that might help us to decide which treatments are best for which individuals. And as Dr. Yang mentioned, CLL is rarely curable, but it may require treatment and long-term follow-up and is recommended for all patients. And this is that part of that active observation series. So what are the primary goals of treatment when it comes to CLL and SLL? And I'm going to lump them together and use the term CLL. And I think one of the things that our goal is to have effective long-term disease control. And that's clear when people are starting to feel unwell and they're starting to have symptoms from their disease, then we want to do whatever we can to help control that process so that we improve the symptoms. And I think the most important thing is that we are improving the quality of life. That's what QOL stands for, quality of life of our patients. And I think one of the things that I think as a clinician I have changed over time is ensuring that I understand what the patient's goals are, in addition to what treatment is prescribed. When we learn how to manage patients in medical care, often it's like, yes, they meet criteria, we must treat. But I think as I have learned through my practice and also in partnership with patients, I think it's very important to ensure that we are making decisions that will improve the quality of life of our patients. And part of that is achieved by respecting their wishes, whether it is to choose treatment or not. And the other part is ensuring that we select with them a treatment that is tolerable for them. And part of this decision is also made based on what their cancer and CLL is like, because it's those molecular profiles that I'll go into detail about, which help us determine which treatments are best for each individual. The second goal of our treatment is to improve the outcomes for our patients. So can we improve the time between treatments? Can we improve the overall survival? The other thing that happens in cancer cells as a whole is if you think about the fact that the cancer cells duplicate and grow and accumulate, what's happening is that if that's happening at a rapid pace, you can have damage to the cancer cell's genetic material that can cause further problems over time. So when we start to see the cancer changing, we want to decrease the ability of that additional genetic stress by treating and controlling the cancer. The other thing that happens when we see patients who require treatment is sometimes their immune system is not functioning in the same way. And so the goals of treatment also include potentially resetting the immune system so that it communicates with the other cells in an appropriate way, such that it improves your immunity over time. And maybe if we think about some of the complications we see with CLL patients, such as second cancers, by resetting the immune system, which we now know is heavily involved in a lot of these other cancers, we might be able to reduce the risk of those second cancers. So what are the main things that we have to think about? So I would like you to think about your cancer cell as something that requires a balance of what we call tumor suppressor genes and oncogenes. And you can think of that as the accelerator in a car and a brake in a car. So if you have changes in the genetic material that are present within your CLL cells, that is the same as your car having the accelerator pushed down and constantly moving forward or growing. And then the other thing is that you need the brake to prevent that from happening. And if the brake is broken and not functioning, then it's like the accelerator is unchecked. So that's some of the philosophy around some of the testing that we do in terms of what's the accelerators and what are the brakes. So a lot of times, if you've gone through this journey, and this is a journey that we're partnering with you on, you will be introduced to the concept of what we call molecular testing. Molecular testing is divided into different types of tests that allow us to understand this genetic information. So one of them is something called FISH, and no, it is not Dory, but it is an abbreviation for fluorescence in situ hybridization. And it allows us to, under the microscope, visualize different changes in your genetic material on chromosomes. So in this picture here, I have a cell. And within this cell is the nucleus. The nucleus is where the genetic material lives. And that genetic material takes the shape of chromosomes. And so the chromosomes are the larger structures. And then if you unravel the chromosome, within it are the genes that are important. And so what this particular test does is a crude test that looks for either losses of certain sections of specific chromosomes where accelerators or brakes may live, or extra copies of the chromosomes that lead to the ability to make more of the protein products of the genes. And it's interesting to note that about 80% of patients will have one of these abnormalities. I think it's important to recognize that some of these are good. So the top one listed here is a good prognostic marker. So prognostic markers help predict what will happen with your disease. And so as we learn more about our treatments, one of the things that we have to understand is the information may change over time. So if we lose a portion of this chromosome, so DEL stands for deletion, and that being a good prognostic marker allows us to understand that this person may do better with certain treatments than others. The ones that really impact treatment as of today is either the deletion 11q or the 17p deletion. And that's because these harbor brakes, which are known as tumor suppressor genes. And these are important when we are thinking of chemotherapy as treatment. Some of these other findings are common in the biology of CLL, but really don't have a clinical implication at this time. So I mentioned that we are looking at the 17p deletion, and one of the genes that are involved when we lose that part of the chromosome is the P53 gene. So sometimes the chromosome isn't lost and is actually intact, but we now have tools to actually look at the specific genes themselves, and the genes can develop mutations. And so now we have technology that allows us to read the gene sequence and identify these mutations that render that gene non-functional. It's not working anymore. And so that's an additional step to help protect patients who might be eligible for chemotherapy otherwise, but if these genes are not working, then we don't want to give them this treatment because that treatment won't be the most effective for them. And the important thing is that these changes on your chromosome change with time. So if you received one treatment, if you require a second treatment, likely these tests will be repeated to ensure we're providing you the best treatment options. The other molecular tests that you'll read about or hear about is something called the Igbh mutation status. So the Igbh mutation status helps us to identify what I would call the immature cell versus the mature cell. The mature cell loses its innate properties to grow and divide as it transitions over time. And so that is a classification known as mutated. And so I cheekily put up the Star Wars picture here because you think of Obi-Wan Kenobi as this mature figure with a lot of knowledge and a lot of power. And so, but he is able to control that power and is able to provide this stable, even keel persona. And Anakin Skywalker is the exact opposite. So that unmutated Igbh represents this innate, raw ability to grow and survive. And that is that unmutated status predicts a more aggressive CLL. About 50% of patients, 60% of patients who require treatment will have an unmutated Igbh. And so this gives you a picture to keep in your mind when we speak to you about those molecular tests. So I think it's also important to note that there are multiple types of treatment that are now available for patients with CLL and SLL, and the majority are not chemotherapy. And I think that's important to note because chemotherapy is non-specific and it works by causing damage to the DNA to prevent cells from replicating. And so this is just a schema to demonstrate all the different steps that are required to duplicate your cells. And these different drugs, which are common in CLL treatment, are often used. But we have now proven through clinical trials that for everybody, chemotherapy may not be the right treatment. There is a small subset of patients in which it still is the best treatment available, but it is not a treatment that everybody would be offered based on that molecular profile and their clinical status. The other thing that I want to bring as, I guess, future hope and excitement is that there is a growing knowledge about the biology of CLL and SLL. And that's because we're starting to learn about which pathways, which are illustrated in this cartoon, among others, that are essential to promote growth and survival. So if we can target selectively the cancer cells signaling pathways that enable the communication for that survival, then we can selectively repress the cancer cell growth while sparing other cells that also rapidly grow, like your hair, your nails, that are often lost in traditional treatments with chemotherapy, but also prevent the damage that chemotherapy does to the body long term, and decrease the side effects from those types of treatments. The other thing that we're learning about is there's also other ways of targeting the cancer cells. So when Dr. Yang talked about the monoclonal B cell, there are certain markers on the surface of this cell as it accumulates to become CLL and SLL, then can be targeted by antibodies that then destroy that cell. So again, another form of targeted therapy that really is able to focus on the cancer cells themselves, opposed to targeting a whole slew of cells. And then finally, one of the things about the biology of chronic lymphocytic leukemia and CLL is that it's not just a growth phenomenon that occurs. These cells tend to accumulate in the blood and in the bone marrow because they have forgotten how to die. And that death process is a term called apoptosis. And so we've now discovered a drug that reverses this process and enables us to reactivate cell death, and that's known as Venetoclax. And so I think what I would like to leave you with today is that the treatments for CLL are changing, and every individual will be approached with the right regimen for you. We need to ensure that the organs that metabolize the drugs, the liver, the kidney, are functioning. We need to know what medical conditions might help us decide which treatment is the better one for you. And also your age may influence that decision making, because some of the treatments can have a lot of side effects and may not be tolerated by everyone. So I think there is a lot of opportunity in terms of the number of treatments we have available for patients, and that number of opportunities is growing. So one of the things we do as a clinic is that we do engage in a lot of clinical trials. So there might be opportunities to participate in trials that allow for newer treatments that are coming around the corner, and learning what's best for every individual. So I hope that you have enjoyed this segment. And with that, I will return the podium to Dr. Yang.
Thank you so much, Dr. Banerjee, for a really nice overview of treatment. And it really highlights how far we have come. And you talked about how much biology we have learned and gained from that in terms of treatment and improving outcomes. And that just really highlights it. So thank you. Now we're going to move on to the next topic, which is now going to be focused on CLL and infections. It's going to be presented by Irina, who is a nurse at Cancer Care, and she's been here for 21 years. She has been in the CLL clinic for 5 years, so she's one of our most senior CLL nurses in CLL. She recently also graduated with a Master's of Nursing in Nurse Practitioner stream, which is a certification very few cancer care nurses currently hold. So without further ado, I'm going to hand over the microphone to Irina. She's actually in the office with me, so we're just going to swap places. So bear with us as we do this juggle here.
Share. Share again. Oh, there we go. Is this me? A couple of others. I'm just go to that presentation screen. One more time.
Great. Thank you for the introduction, Dr. Yang, and good evening to everybody. I'm just going to take a few moments today and we're going to talk a little bit about CLL and infections. And so here we go. So just like Dr. Yang had initially talked about in her presentation, we know just by virtue of having CLL, patients will have a weakened immunity. So CLL can alter the function of your immune cells, thereby putting you at higher risk of developing infections and by not being able to fight infections as well as perhaps someone without CLL. Any of those infections can be caused by viruses, bacteria, they can be caused by fungus, and we can see those develop whether, you know, they're in your bloodstream. They can be skin infections, they can be sinus infections, respiratory infections, pneumonias, colds, and then bladder infections, which may present as urinary tract infections. Having said that, not all patients that are on treatment are susceptible to infections, meaning that people that are not on treatment as well can be just as much at risk. So it's important, and you'll notice when you come into clinic to see us that, you know, this is one of the important topics that we're asking about. So we want to know, you know, since we've seen you last, have you had any infections? Have you had to use any antibiotics? And those are some things to keep in mind too in between visits. And if you are developing more frequent infections requiring, you know, antibiotics or even hospitalizations, those are important things to let the clinic know. So what you need to know in terms of infections is immunization. So we do encourage everybody to get the flu shot every year. We also encourage you to get the pneumococcal. We also encourage you to get the Shingrix. And so if you have questions about your immunizations or need to kind of know, you know, what do I still need? What can I get? Those are really good conversations you can have with the clinic nurses or the physicians when you're coming in, and we'll be able to advise you on what you need to make sure that you're up to date. Avoiding live vaccines. So the only live vaccine that I can think of that, you know, we used to tell our patients not to get was the Zostavax, and that was to prevent shingles. Shingrix is the newer product now. It's a 2-dose immunization that can be given, and if you do need to have that done, you can again run that by the clinic, and we can, you know, provide you with the advice of whether or not it's appropriate for you. If you start developing infections, have the need to have antibiotics more often, you may be eligible for immunoglobulin replacement. I will talk about that in a few more slides and let you know what that program entails. I'm going to talk briefly about CLL and COVID. We've all been kind of impacted and had you know, I'm sure there are a lot of questions out there about how COVID will impact you and those with CLL. So Dr. Yang was able to share some data with me in just terms of, you know, we're just getting to know some of the research and how, you know, CLL patients will respond. We know there are complications and risks associated with our patient population having COVID, and that, you know, would mean hospitalizations, obviously a risk of death if you were to get very ill from the COVID. Response to vaccination is low. It's lower than it would be in the normal population. However, we do know that as you continue to get immunized, so your first and second doses, then you've, you know, hopefully had the third dose, and now being eligible for the fourth dose, we know that there is some response with the subsequent doses. One of the studies from, this one is from 2021, looked at response rates to the COVID vaccination among patients with CLL according to treatment status. So in this study, they looked at 167 patients, and in that group, they had 2 doses of the mRNA, so that would have been either the Moderna or the Pfizer. So patients that had completed treatment and were in remission were shown to have about a 79.2% response rate to 2 doses of the COVID vaccination. Treatment naive patients are those that have not had any therapy to date, and they had a response rate of 55.5%. And those that are on active treatment, so that was ibrutinib, venetoclax, and obinutuzumab, had a 16% response rate. So for COVID and what you need to know, immunize, immunize, immunize. So we encourage you all to get your immunizations. Hopefully by now, most of you have had at least 2 doses, if not your 3rd booster. And for those over the age of 50 currently, and if you're 5 months out from your 3rd dose, you are eligible to have the 4th dose. So if you're coming into clinic in the next few weeks, we can provide you with a letter to have that 4th dose done. Otherwise, I would encourage you all to call your clinic nurses, and we can have a letter mailed out to you so that you can go and get that dose. Another thing that's important is if you do test positive to COVID, whether you've done a rapid test at home or have had a PCR test, we are encouraging you to let us know in the clinic. Why? You may be eligible for a monoclonal antibody or antiviral medication if you test positive to COVID. And we would like to at least know that you're tested positive so we can assess whether or not you would be eligible for the treatment. Normally, it's patients that are on active treatment or those that have immunocompromised systems that are on either IVIG replacement therapy or have had infections. That seems to be the criteria right now that are eligible for that. So it's time sensitive as well. So, you know, the criteria wants you to have symptoms within, it's 5 to 7 days of testing positive. So again, that's why it's really important if you do test positive that you let us know. And then in terms of protecting yourself, just while we don't expect everyone to live in a bubble, and you know, life is important and we have family and children and grandchildren that we want to spend time with, we do want to encourage you to just use some common sense. Think about the situations that you're getting into. While masking, you know, mandates have changed, we still are encouraging you to protect yourself, protect your family when you're in large group situations or in, you know, a situation where you're just uncomfortable. And again, at any time, if you have questions or concerns, you're more than welcome to call us at the clinic. Lastly, I'm just going to talk about the subcutaneous immunoglobulin home infusion program. And so this program is available to patients that have low immunoglobulin, have had several infections requiring either antibiotics or hospitalizations. This is a picture of the lovely nurses Lindsay and Brittany who are running the program right now, and Erin Richard is another nurse that does help the nurses out on occasion. Unfortunately, we just didn't capture her picture. So immunoglobulins are these special antibodies that help us fight infections. So we measure these at, you know, random periods, usually when you come as a new patient, and then, you know, physician dependent on how often we're, you know, seeing what those levels are like. There are 5 kind of immunoglobulins, but the IgG is the most common, and that's the one that we can replace. So we can provide IV or IgG replacement in two ways. One way would be intravenously, where you would come here into the treatment room and receive a dose. It's usually once a month, or subcutaneously, where you would provide the infusion to yourself at home. Immunoglobulins are provided by the Canadian Blood Services and are collected from, it's made from blood donations from people. The advantages to the sub-Q program is that it's a home infusion program. You can, usually in clinic, we will kind of assess whether this is something you yourself can infuse, if you have a partner at home or somebody that would be willing to help you with that, if maybe it's something you don't think you can do. In some rare cases, home care will help us with the infusions, and the nurses here will teach you how to administer it. Often it's just given once a week. You're sitting on the couch watching the news and you're infusing yourself. The benefits are that you can have a more steady level of IgG. We're avoiding veins, and it's just something that you can infuse into your abdomen or your thigh. There's low risk of side effects, and you can, again, have the convenience of doing it at home on your own time and incorporating it into your schedules. Lastly, I just was going to show a slide. This is courtesy of Dr. Johnston. He just wanted to he was showing us about, this is an example of a patient. If you look, I don't know if I can move my mouse. So this is a gentleman that had very low IgG levels, as you can see. And often too, like Dr. Yang and Dr. Banerjee had spoke about, often if you start getting more and more infections, that sometimes too is an indication to us that, you know, your CLL is becoming more active and we're going to have to start looking at treatment. So this was a gentleman with low IgG levels. He had presented with numerous respiratory infections. He had a skin infection. And as you can see, he was started on ibrutinib therapy at the same time. So we started Igbh with him. He was getting 3 grams a week, and that would have been, I guess, back in February 2018. And as you can see, this was initially, so he had a good boost of the IgG level, and it's kind of maintained himself. It did drop down again, and at this point, it's, you know, may have been too, he was getting resistant to his ibrutinib therapy and had to switch. And as he went on to Venetoclax and his disease became more stable, he had a continuous rise of the IgG level again. And I can say that he's been infection-free for over a year and doing well with the treatment at home. I asked the Igbh nurses actually the other day, and so right now, currently, we have about 82 people on the program. So it's been a positive experience, and I think, you know, something that, you know, we definitely can help you with in helping prevent infections. And that's it. So thank you.
All right, so we are now switched back. Thank you, Arena, for that really nice comprehensive talk and very relevant talk that I'm sure we're all excited to hear about. We will now move on to hear from Max. And let me introduce you to Max. Max is our clinical research assistant, who is the communication bridge between the research institute and the clinic. He recently graduated from the University of Manitoba Science Microbiology program. He's worked in the research institute for the last 2 years, looking at blood cancer, CLL, particularly biology, and metabolism under the supervision of Dr. Varsha Banerjee. He has an interest in learning about the general operations of the joint clinical and research aspects of cancer care, and is interested in continuing his patient care. So without further ado, Max, you want to take it away?
Yes, thank you so much, Dr. Yang. Okay, just going to share my screen. All right. Can everybody hear me and see my screen?
Yes.
Yes.
Thank you. Yes. All right. So once again, hello, everybody. My name is Max, and
my name is Esther.
Yes, and as Dr. Yang has mentioned, we are both clinical research assistants at the Research Institute of Cancer Care, Manitoba. So I'm going to be talking about our CLL research program at the Institute of Cancer Care, Manitoba. So you probably saw Esther and I around at the clinics during your visits, where we either approached you, called you, or consented you to the Blood and Bone Marrow Disorders Bank. So I will just be spending the next few minutes talking about that. So I know this slide looks a bit busy, but it basically shows the journey your donated blood would take once you consent to be part of our research program. So that would be organized by myself, Esther, or any other clinical research staff in the Manitoba Tumor Bank. So I split this diagram up into two parts. The first part is what you would see coming into the clinic. So part A shows what you would see coming into the cancer care clinic. So you would go and do your blood work at the hematology lab on the first floor. And then you would go up to the third floor, usually to see your primary care providers. So the second part of this diagram is not, I intentionally did not put it in this boxed cluster of images, because this is what happens behind the scene. So it's basically what us researchers see behind the scenes. So usually as we give you the pitch, we usually de-identify and make sure that the researchers don't know your personal information. So this is like my way of showing how we block that connection off. So we give you study-specific codes, and the researchers would only basically see your blood coming in from the tumor bank after it's processed. So it's also, so part B is more for you to show you the behind the scenes and the amount of work it takes to make sure that your blood sample could be used to its full potential. So starting back up here, once your blood is drawn at the hematology lab, it is brought upstairs into the Manitoba Tumor Bank on the 6th floor to be processed, and then from there handed off to the researchers, CLL researchers on the 5th and 6th floors of the Research Institute. So then these researchers will experiment on and generate important findings to pass this knowledge on to other researchers and healthcare workers in order to gain a better understanding of the disease and to potentially establish better ways of treating CLL worldwide. So this slide is just a little visual for you to see. So this is just the outside of Cancer Care Manitoba. I'm sure everybody's familiar with it, but I'm sure a lot of you have never been on the 5th and 6th floors. So on the 5th floor, we typically have all of our research laboratories. When I was a student 2 years ago, I spent a lot of time on the 5th floor. So this is just one of the research labs. They're all around the 5th floor. This is an image back view of the Manitoba Tumor Bank. So this is where your blood would be processed if you donate it for research specifically. So this slide is also just a visual to show how blood is processed in the Manitoba Tumor Bank. So it is usually done inside of a biosafety cabinet, which is in the corner right here. And here we have Monroe, one of our Manitoba Tumor Bank lab technologists, processing the cells, basically being in action underneath the cabinet. So basically how they process your blood or the donated blood would be by putting it into, so there's a vial of blood right there with all of its contents completely mixed up. So they would put it into a machine called the centrifuge, which basically spins at very high speeds that separates its contents based on its density. So here we have our plasma floating on the top layer, this yellowy clear layer. Then we have our red blood cells at the very bottom, very dark red. And then right in the middle, this white band is our the CLL cells, where we would typically they would extract, and then those are the cells we would use for research. And then of course the Manitoba Tumor Bank also freezes plasma and red blood cells for later use. Next slide. So this slide emphasizes that when you participate in research, you are also part of a larger team that's making a significant impact on the lives of other CLL patients and CLL research globally. So every researcher pictured here carries a variety of different expertise that looks at different aspects of CLL, such as, or for example, age, frailty, mitochondrial energetics, as Dr. Banerjee has mentioned during her presentation, and a whole other lot of biological markers that are found within these cells. So together, we can help each other understand and learn more about CLL, even more than what we know today. So this top set of pictures are our team at the Manitoba Tumor Bank, a bunch of wonderful people that I love working with every single day. And then at the bottom here, we have a couple of lab pictures that were taken the last couple of years with a bunch of PIs, laboratory technicians, and trainees or students. So speaking of students, finally, the success brought by the Research Institute in Cancer Care Manitoba gave the resources to support many types of trainees, such as co-op students, which I was one of those people, summer students, graduate students, medical students, and even residents to become future researchers and even medical professionals. And then there's another lab picture here that I could find. So yes, that was it. Thank you very much.
Thank you, Max. And I apologize for not introducing Esther in the beginning. Esther, do you want to put your camera back on? She has recently joined our program as well, and you will see her with Max for the most part in the clinic when we are introducing them. So we're very thrilled to have her with us. And so with that, we will move on to another hot topic that everyone's excited about, and that's looking at nutrition and cancer, and particularly CLL. And we're very pleased to have Ranu with us. Ranu has been a dietitian for over 20 years now. She has joined Cancer Care Manitoba in 2018. She specializes in helping patients with heart disease as well as those with cancer, so very relevant. And we look forward to your talk, Ranu. Welcome.
Okay, so I'm just going to share my screen here. Thank you, Dr. Yang. Good evening, everyone. Today, I will be discussing eating well after a CLL diagnosis. I will cover the benefits of good nutrition, the importance of protein and fluids, weight changes, specifically weight gain and weight loss, managing treatment side effects, vitamin D, sugar and cancer, and nutrition services at Cancer Care Manitoba. So to begin, the benefits of eating well is one of the best ways you can keep your body healthy before, during, and after treatment. It supports immune function. It improves strength and energy, helps with recovery and healing. It also prevents unwanted weight loss or weight gain and minimizes muscle breakdown. So on that note, let's begin with the importance of protein. Protein plays a vital role. It's needed for growth, repair, and maintaining body tissues, maintains a healthy immune system, is the building blocks for cells, helps to prevent muscle loss, and during active treatment, the body may require extra protein. Here are some examples of high protein foods. So this slide shows animal food sources of protein like milk and milk products, eggs, meat, chicken, and fish. Not only are these foods a source of protein, they also provide vitamin A and D, iron, and calcium. Moving on, this slide shows plant sources of protein like soy, different kinds of beans, lentils, split peas, nuts, and seeds. Again, these foods are full of protein, but also provide vitamin E, magnesium, and potassium. Next, I want to discuss the importance of fluid intake. Drinking an adequate amount of fluid helps to prevent constipation, helps to maintain a normal blood pressure, helps to control body temperature, and of course, lowers the risk of dehydration. Generally, most people need 1.5 to 2 liters of fluid daily. Fluids include water, soup, coffee, and tea. Next, I would like to discuss weight changes. Goals around weight can vary among people. So let's begin with some tips to achieve a healthy body weight. To achieve a healthy body weight, have a variety of natural whole foods along with minimally processed foods, like including a source of protein at every meal, eating more vegetables as they are packed full of nutrients. At breakfast, add them to omelets. For lunch, add them to homemade hearty soups, or have a variety of salads. For dinner, roast, steam, or stir fry them. You can even try zucchini noodles or cauliflower rice, even pureeing them into a sauce. Also, add healthy fats like olive oil, avocados, nuts and seeds to meals or snacks, as these help with satiety and promote less overeating. For carbohydrates, consume the nutritious sources like whole grains, quinoa, oats, vegetables, and limit the non-nutritious sources like pop, white and brown sugar, honey, and fruit juices. You want to really limit fast foods and other highly processed foods. Instead, try preparing fresh home-cooked meals. Watch portion sizes. Use a smaller dinner plate so you'll naturally just eat less. Drink an adequate amount of low-calorie fluids like plain or sparkling water and plain tea and coffee. Moving on to tips for managing unintentional weight loss. Unintentional weight loss, which can be a symptom of CLL for some, is often because of poor appetite or lacking the desire to eat. So to help, we recommend don't wait until you're hungry, just eat. Eat frequently throughout the day. Think of food as medicine. Include nutrient-dense, high-protein foods. Liberalize healthy fat. For example, switching to full-fat versions of milk and milk products, adding full-fat milk or cream, to cereal, cream soups and smoothies. Use extra olive oil, sauce, or gravy to snacks or meals where appropriate. Using avocados or peanut butter as a spread, or even adding that to a homemade smoothie. Even trying ready-to-drink liquid nutritional supplements can help. The next topic is managing side effects. Treatment side effects vary depending on the type of treatment. For example, the side effects of targeted therapies are different from the side effects of chemotherapy. Patients react to treatments in different ways. In terms of nutrition, poorly managed side effects will lead to eating less and losing more weight, versus well-managed side effects will result in adequate eating and less weight loss. Next is vitamin D. So vitamin D is the only nutrient your body makes when exposed to sunlight. Vitamin D deficiency is common because people may spend more time indoors, especially in cold weather like Winnipeg, or because, we have to wear sunblock when we're outside. And some people just may not get enough from their diet. Some food sources include eggs, fish, milk and milk products, and the recommended intake is 2,000 international units, and that should be coming from food and supplements. Moving to sugar and cancer. Does sugar cause cancer? This is a common question we get. Sugar itself has not been proven to cause cancer. Sugar may trigger insulin levels. I do want to share that cancer growth, or how it takes nutrients from cells, is very complex. And so for that reason, we don't have all the answers. Insulin may be a factor, but it's not the only factor. Insulin is a potent growth factor for healthy cells and maybe for cancer cells. In general, more insulin means more cell growth. The role of insulin and other growth factors in cancer still needs further research. Really, our bodies don't need a lot of sugar. We eat it because it tastes good, and most people eat too much sugar. So the bottom line, try to limit your sugar intake from sources like sugary drinks, specifically soft drinks, sports drinks, energy drinks, iced tea, and sugar. Also limit foods with added sugars like candy, cakes, cookies, pies, pastries, and ice cream. All right, nutrition services at Cancer Care Manitoba. We accept referrals from any member of the healthcare team and from patients. Currently, due to COVID, appointments are over the telephone. You can contact nutrition services at the number on the screen to meet with a dietitian. Thank you. Back to you, Dr. Yang.
Thanks so much, Ranu. That was really informative. Very, very nicely done. So our last item on the agenda is to invite Jerry to speak with us today. I'm very pleased that he has come on board and willing to share his experience. And I won't introduce you because I think you will introduce yourself. And, and I look forward to it. So thank you for coming.
You're welcome. You're very welcome. My introduction is, I consider myself lucky. And why is that? Well, I'm happily married. We have a daughter, and I enjoyed a great career. So my story is that a regular doctor's appointment was I was about 65 years old. I was labeled and considered a healthy male. And why not? I was aware of healthy foods. I didn't smoke. I maintained good body weight. I was physically active, and I kept my mind occupied with a variety of projects in our community. It sounds great, right? Perfect, in fact. And on my next medical appointment, everything was still good. Good cholesterol levels, good blood pressure, weight was fine, everything. Everything except a slight increase in my white blood cell count. So my family physician sent me to another physician for just a little bit of further investigation. And that's how it started. First, a bone biopsy, then the results and the diagnosis, CLL. My reaction? It can't be. Maybe it's a mistake. I've done everything to prevent something like this. I was even a little bit embarrassed. I didn't know what I was going to say to my wife. I wanted to fix it. After all, I'm male, I'm a husband, I'm a dad. I can fix things. I definitely don't want anyone to worry about this. I wonder, could I eat more broccoli? How about more salmon? Eliminate sugar from my diet or increase my morning oatmeal. I was looking for something to do. I needed something to heal myself. I read an article somewhere where asparagus shoots had the ability to level blood levels. So you must already know what I did next. I went to the grocery store and I bought asparagus. And for the next couple of weeks, I ate a few shoots of asparagus every morning and every evening. Believe it or not, it helped. And now I know what you're thinking. It didn't do anything for my blood levels, but for a short period of time, I was doing something that I could control. I felt a little bit of control again. At my next blood work, I was hoping so much that my white blood cells count would be back to normal, or at least show a little bit of signs of improvement, even slightly. The results of my blood work showed an increase in my white blood cell count. The realization that I did have CLL was beginning to be real. Then came, why me? My neighbor smokes and he doesn't look after his health at all. Why not him? Why me? When I spoke to my doctor, he asked if I had any symptoms. Night sweats, dizziness, tired, unable to do daily activities like walk around the block. I had none of these. Now comes denial. Well, maybe I need a second opinion. Before this happened, my first symptom did appear. I developed lumps under my armpits and on my neck. I checked them daily for about a week, hoping that something would change or they would go away. Another silly thing I heard. If you jump up and down slightly, it has the ability to reduce some of your lumps. So privately, I would go to the basement and do 100 jumps. Sounds silly, doesn't it? I fell into the category that probably so many people fall into. We would do anything to have a little control. Well, what did help me was meeting Dr. Banerjee. She was factual. She explained in detail and with time what was happening to me. She was optimistic, but most of all, she listened to my concerns. Today, I do regular blood checks. I am controlled with medication. They control my white blood cells. I visit my doctors, but most importantly, I am enjoying my life again. I consider myself lucky again. I'm back to being active. I'm back to being the person that I once was. Now I try to see all the things that I do have and not the things that I don't. I'm still married. I still have a wonderful daughter. I had a wonderful career. And now I do things that make me feel valued again. Right now, I belong to a committee that is bringing families from Ukraine to our community. Life is far from over. One of my favorite sayings comes from one of my students when I taught. This is my saying, his saying. We are not put on this earth to see through people. We are put on this earth to see people through. I have many people who help me see me through life. Lucky? Yeah. Thank you.
Thank you for sharing.
You're very welcome.
So inspirational and so heartwarming. Choked up a little there.
Oh, good. Thank you.
Yes, and to share that personal story with us, we value it so dearly.
Thanks. I hope it helps.
Yeah. So we're completed the formal agenda for the evening, but I would like to open and encourage people to now ask us any questions. We're going to ask the panels to kind of put their cameras on so that you're visible to the audience. And we're going to just start going through the questions. And I just encourage people just type them in the Q&A, and we're going to answer them one by one. So we have 4 so far, 3 for Dr. Banerjee. So what I'll do is I'll answer the first question that I think came up during my talk, and then I'm going to propose questions to Dr. Banerjee and have her answer 3 really good questions about treatment. Okay, so the first question came from Sarah, asking about screening family members for CLL, if we're concerned, because I had alluded to that there is a small group that there's hereditary component. So her question was, how do we screen? Do we just go and ask a family doctor, or is there a screening test that they can do? So we did have a study here many years ago, and Dr. Banerjee will speak to that study, when we looked really hard about family prevalence and inheritance and coupled that with genetic testing. But as far as I'm aware, that study is complete. So for now, if you are wanting to screen family members, then the natural thing to do is have that family member go to their own family doc and just get a screening blood count, which is what people do when they go to a family doctor for clinic visits, physical exams. A blood count, a standard CBC, complete blood count, comes with all physical exams nowadays. So if that blood test shows changes in the white count or the lymphocyte, there may be a clue that there needs to be a next step to see what are those lymphocytes. Are they CLL or are they not? Sarah asked about checking platelets, but I think it's more so the lymphocyte count that we're looking for, the part of the cells that are part of the cancer CLL cells are expanding. So I hope I answered that question for you, Sarah. Did you have anything more to add, Dr. Banerjee? Because you were part of that genetic study.
Yeah, so I think it's important to recognize two things. One is the risk of screening, and two, when is it appropriate? So I think at routine blood tests that are being scheduled by your family doctor, and your routine visits would encompass this. But the recommendation for familial screening for this disease has a double-edged sword to it. The first is early diagnosis of a cancer may have insurance-related implications. So for financial reasons, life insurance, things like that. So the recommendation for family members is if you have a strong family history and you're concerned and you're going for your routine blood tests and checkups, it will be captured in that process. But we hesitate to recommend people going out and advising their family members to do this because early detection doesn't mean early treatment, but it could have other implications for your health, job, things like that. So I think I do want to be clear that routine screening, unless you're symptomatic or having your regular checkups, is not recommended.
Yeah, that's an excellent point. So thank you for bringing that to the discussion. I am managing the chat, the Q&A, so excuse my gaze at points. So the next three questions are for Dr. Banerjee related to therapy. And if more comes up, I'll add to that as well. And they're excellent questions coming from Paul and Savvy, if I'm not mispronouncing the name. Savvy, thanks you very much for a really informative session. The questions from Paul are, the first one is, he clearly describes that chromosomes are paired, half from mom, half from dad. When you talk about these mutations that we're looking for in the molecular CLL molecular profile and talking about deletion chromosome 17 or other chromosomes, his question is, does that mutation have to happen on both chromosomes, both chromosome 17, or does it happen only one? And secondary to that is, if you only have it on one chromosome, does the good chromosome compensate for that loss? And is that enough?
So those are really, really excellent questions. So the reason we expanded a lot of our testing was that when we did the FISH testing, we would capture about 90% of people with a 17p abnormality. And the assumption was that if you lose one arm of the chromosome, that the other arm has a gene that's not functional as well. But there were 10% of patients you would miss because they would have intact chromosomes, but the genes themselves had a mutation. So the reason we expanded the testing was to include that 10% of people that we would otherwise miss. And the reason this is important is that those patients with a 17p deletion should not get chemotherapy. So by identifying the P53 mutation in the intact chromosomes, we would then be able to save that percentage of patients from actually receiving chemotherapy. And that holds true also for that 11q deletion as well, is that there is often a mutation in the partner gene as well, rendering both alleles non-functional. There was a second part, but I don't remember the question.
I think you've answered it.
Okay.
His question was, if you had the mutation only on one chromosome, does the good chromosome compensate for that loss? So do you have to have deletion 17p on both chromosomes?
Yeah, so no, and we know that single loss does influence the ability for chemotherapy to work as well.
Good. Paul also had two additional questions, and I'm just going to ask them all together. his next question was about Venetoclax. He asked if Venetoclax is good for a variety of cancers in addition to CLL. And he's asking for this in regards to his indolent prostate cancer that he's been diagnosed with. Would it, I mean, I'm thinking that he's implying, would it work in that situation?
Venetoclax is being studied because of its ability to reactivate the cell death process in a lot of different tumor types. But the majority of them, I would say, are in the blood cancer field. So we know that it is working in CLL and other acute leukemias where the protein that it targets, BCL2, is upregulated. And so there are ongoing studies across multiple different diseases to see if this might also work. So at this point in time, it is not an approved therapy for prostate cancer.
Yeah, that's really interesting because it's a BCL2 inhibitor, and BCL2 is the gas pedal in your scenario. So you would think that a lot of cancers would have this gas pedal and Venetoclax would then work, but that isn't so. It's very specific to certain types of cancers and not all kinds. Yeah, so that will play out in time. Savi had the question again, also about Venetoclax, and his question was, what stage is it? What stage of CLL would you be prescribing Venetoclax? That's a bit of a complex question there. So.
Yeah, so I did not go into the treatment algorithm, and I thought of it more of as at what point in the CLL journey is Venetoclax used. But this is the approved Canadian algorithm for the treatment of CLL. And it does classify patients into multiple categories. So the young fit patient where chemotherapy is the standard of care. And for those that are not fit for this treatment, these are the multiple options. So either chemotherapy, because that's a choice that they've made and their disease will respond well to it, or Venetoclax in combination with obinutuzumab. So as of 2022, January 31st, multiple provinces, including ours, have now have this regimen funded. We have actually adopted this line of therapy since the middle of last year, and a lot of our patients have already received it. For those with high risk factors, because they don't respond well to these time-limited treatments, continuous therapy with the BTK inhibitors, acalabrutinib and ibrutinib, are used. When their disease comes back or is no longer responding, those patients automatically go on to Venetoclax. For those that received a time-limited treatment option, there is the possibility of them being retreated with a Venetoclax-based therapy or going on to a BTK inhibitor. So that should answer that question.
Okay. I am going to speak to a different panelist, and then there's more questions for you, Dr. Banerjee, coming up, but just to spice it up a little bit. So there's a couple of questions for you, Jerry. Somebody wanted to know a couple of things. One is, how old are you now? And the second question is, did you have chemotherapy? I don't know if they meant chemotherapy or just therapy altogether, and whether you're relapsing now, and how essentially how the course of the CLL treatment has been.
Right. Okay. I said I started at 65, but at 65, I've decided to now decrease at every birthday. So I am really not 72. I am now 58. So it's just, I like that math much better. After a certain length of time, I am on medication called Calquence. And the medication has been on for 4 months, and I have, I think, good success with it. I look at my numbers. My physician locally tells me they're constantly improving. And when I went to Winnipeg to see Dr. Banerjee, she was, this time she had a bigger smile on than she usually does. So you can see it right now. So then I knew I was on the right path. You know, I'm giving her all the credit. I have Nurse Lindsay there too. She was really, those two are the team. I first met Lindsay and then Dr. Banerjee, and I truly am not polishing her elbows. I am simply saying they really do treatment of the person, not just of the disease. And I really, because it is me, it isn't my disease that she was working with. And I really say thank you, and I appreciated that. It made a world of difference. So a tissue for me now.
Good. Excellent, excellent. Ranu, a question for you. I've lost track who's who now, so I'm just going to ask the questions as I'm writing them down. Someone stated that they take a multivitamin. They want to know if that's enough in terms of vitamin D, or do they have to take additional supplements, or what else would you supplement in addition to a multivitamin?
So depending on how much vitamin D is in the multivitamin, and sometimes it can be low, and also it depends on how much you're getting from your diet. So those two things, we sort of have to figure out how much you're getting. And typically, what I would recommend is you may need an additional supplement to help get you that 2,000 international units a day.
Okay. Irina, she unfortunately doesn't have a camera now because I had to take over. So she will be with us in voice. The questions regarding Shingrix. Somebody had Shingrix, which is the non-live shingles vaccine. They want to know how long is it effective? Do you have any ideas, or do we have any studies on that?
So
I guess in CLL patients.
Yeah, can you hear me?
Yes.
Yeah, so my understanding is, and just actually it's from when I was doing some of my master's work, that it's good for about 4 to 5 years. And I mean, I recall having this conversation with one of the practitioners I was working with. So, I mean, I could look into more detail, obviously, and in terms of, I don't really know any of our patients that have gone back to get re-immunized after it, but from what I understand, I think some of the clinical trials say it's effective like 4 to 5 years. But I couldn't, whoever had that question, if they want to call me, I can definitely look it up a bit more and have a more concrete answer for them. Or if anybody else, Dr. Banerjee or yourself, know the answer to that. But
I'm not sure if we have the answer for Shingrix in CLL specifically, because that's a bit of a niche population that I don't know if studies are out there. Traditionally when they do a vaccine study, they just put it to the general public and study efficacy that way. I'm not aware of any CLL specific studies and Shingrix to see how long, how many percentage of people mount a response and how long does that response last. Are you aware of any, Dr. Banerjee?
I would agree that I don't think there's any formal recommendation for repeat vaccination. I think the evidence for the vaccines that have been around longer, such as pneumococcal vaccine, have that vaccine information available. So typically the two-step is provided at diagnosis, and then 5 years later we do the booster shot. But at this point in time, as far as I know, there's no recommendation for boosters for Shingrix vaccine.
I am going to go back to some fundamentals in CLL. There's a whole slew of them. I'm going to just propose it to you, Dr. Banerjee. Some of it did come from my section, but I'm trying to manage the questions and I won't be able to do both. So someone asked, what causes CLL? It's a big fundamental philosophical question. Are you able to provide some insights?
So I think from is there a specific event that happens that you were exposed to, or is there something in your genetics that predisposed you to developing monoclonal B-cell lymphocytosis, SLL or CLL? The answer to that is likely we do not know. There are some thoughts that there is the hereditary component where 10% of people in a family may have the same disease. But what we don't know is it because they were in the same household, were exposed to the same environmental phenomenon versus is it genetically passed down? And so I think there is some data to suggest that there are some susceptibility factors in people's genetics that may predispose people in families to specific blood cancers. I do see there's a question about Waldenstrom in a sibling. And so, you know, this might be some of that susceptibility that is there, but it's not that any one thing that anyone has done would cause them to have CLL. So I think it's really important, as Jerry alluded to, that this is nobody's fault, and it is something that happens. If we think about it as a process of aging, it might explain things. And so we are living longer than anyone has ever lived before. And we are having more opportunity to develop things that are age related. And so our cells are used to functioning at a certain capacity, at a certain rate, but then they start to lose those natural protective measures that keep the cell healthy. And so if we think about CLL as a disease of aging, some people might be aging at an accelerated rate than others. And so this might be the reason why we see this wide range of people with this phenomenon. And in other cases, it might truly be the biology of the actual survival signals that are activated in other individuals. So I think we're starting to learn more about this. A lot of people are studying aging as a process in the development of cancer as a whole, and that different cells might age at different rates, and therefore those safety mechanisms we have to keep that cell healthy are failing. And we are now using our medications to really reset those pathways and that biology such that the cell forgets that it's aging, and therefore, you know, we control its growth. And that's how you might think of some of the treatments that we're initiating now.
Okay. Great. So the next set of questions is about relapse and response to treatment. And then we have a whole slew of questions about molecular testing, which I kind of lumped together. So starting with relapse and response, there were two questions. One is saying, what are the odds of getting CLL more than once? So I think they're alluding to relapsing, like you treat and it goes into remission and then it comes back. And then somebody else asked, how likely is CLL going to remission? So I think they may be asking similar questions, so I've lumped that together.
Okay. So I think it's important to note a lot of the literature that is available on the internet and that even are presented in the presentation reflect two different treatment courses and what happens if you get them. So one of the treatments time frame is what we call time limited. So someone's getting 6 cycles of chemotherapy or 12 months of venetoclax and obinutuzumab, or 2 years of venetoclax and rituximab in the relapse setting. So those are what we call time-limited therapy. The idea is strong, powerful treatments that get a really good deep response that lead the patient to get into remission, and then the drug stops, you stay in a remission for a while, and then what happens is slowly the cells start to recrudesce or start to increase in number. And the reason for that is it doesn't matter how good our technology is, we can measure how deep that response is in clinical trials, but the reality of the situation is likely these treatments are not getting every cell. And so over time, that accumulation of those abnormal cells comes back, and then the CLL needs to be treated again. So just because the cell number comes back, or just because your lymph nodes are big again, that doesn't necessarily equate to treatment. We might wait till you get symptoms again or abnormalities in those blood tests before we need to treat you. However, what can happen depending on what treatment you received in the frontline setting is that there may be another time-limited treatment that you might be offered. We often don't use chemotherapy twice anymore. I think that is old practice. If you got chemotherapy in the frontline setting, the chances are you're going to get a novel agent in combination with an antibody in the second line treatment, as long as you don't have the abnormal molecular features that put you in the highest risk category, which is that 17p deletion or the P53 mutation. If you have those abnormalities, typically we would avoid those time-limited treatments because we know that your time off treatment may not be the best, and you would require treatment earlier than the average response times for those treatments. That being said, another high-risk category is the IGVH unmutated status. So some patients may be on those continuous treatments. So in that patient population, it's important to note that their disease is controlled on treatment. The treatment is there and it's holding their disease at bay. So at some point in time, that disease will no longer respond to the treatment. And that's a different scenario. That's a scenario in which that treatment is no longer working. We would not repeat that treatment, and we would have to move on to another type of treatment. But we don't wait for you to develop symptoms. We don't wait for you to have really large lymph nodes or high white counts, because the scenario is now changed. It's not that you went from a treatment-free period and remission to requiring treatment. You are on a treatment and it's not working anymore. And often the disease is speeding up and requiring treatment sooner than later.
I may have missed it, my apologies. We talk about the efficacy of the treatments. Do you have a general ballpark of how good the treatments are?
So I will say the treatments for CLL are pretty awesome altogether. So if we think of the young fit patient in terms of FCR, it has the most data around it. And in the lowest risk patients, those who are mutated with no other molecular abnormalities, we have 17 years of follow-up, where on average, most patients can respond anywhere between 5 and 7 years or longer. Those that were treated with that regimen at an earlier time point when we didn't have this information about the molecular treatments were those that relapsed earlier and then went on to second line treatment. If you get ibrutinib, acalabrutinib in the frontline setting, and even in the relapse setting, the average response for all patients in the relapse setting is somewhere between 5 to 7 years for those that are lower risk. In those that have a 17p deletion, that risk might be closer to 5 years. And the majority of patients, up to 80%, have that type of a response. And when it comes to the Venetoclax-based regimens, right now the data is early on those. And so we know after 4-year follow-up, about 75% of patients, when we've stopped treatment, remain in remission. And so I don't know that there's a bad treatment for CLL for anybody, whether it's observation or someone on therapy. Everyone really has benefited from the last 10 years of clinical trials that have provided us with the best treatments based on the biology and the molecular profile of that patient, leading to that personalized medicine.
Yeah, I think we've come a really long way, and now we're just matching up, so to speak, the treatment with the right patient. Yeah. So you talked a little bit about profiling. So there's some questions about that. Somebody wanted to know that is molecular testing done at every time with relapses? If so, is that result shared with them? This is somebody who's speaking for their mom who is on ibrutinib and transitioning to a new treatment, would you do molecular testing, and is that needed? And
yeah, so I think there's information that definitely helps understand the disease better, and then there's the information that is necessary. So it really does depend on what that molecular profile was prior to ibrutinib. Now, there's a group of patients that we didn't have all the testing. So if I'm missing testing in the relapse setting, I often will repeat the P53 mutation status or the Igbh if it wasn't done. We only started doing those two tests in 2018. So if you had your diagnosis before then, or required your treatment before then, I should say, then that testing wouldn't have been done. So I think when I'm trying to decide between a continuous therapy versus a time-limited therapy, the information about the FISH and the P53 status is very important because we know that the continuous therapies with the BTK inhibitors do provide the best remission. When it comes to Igbh status, it really depends because some of the treatments, even the Ven-O, for example, which is time limited, or the VR, actually have really good results in that patient population. And so that's where we have the discussion with the patient about, you don't have any of the super high risk features, but this is one of the high risk features. Are you able to come in for Ven-O? There's an intravenous component, there's a lot of blood test monitoring, or is for your quality of life an oral treatment that's done in the comfort of your home where you can partner with care in your rural location better for you, right? So those are things that we can work on, because I think the other thing that our group really is trying to do is improve the accessibility of all treatments for all of our patients, but also provide an avenue for patients to get very effective treatments based on what their wishes and quality of life measures are. And some of that is being close to home and not having to travel. And those are important things for us to consider.
Thank you. There was a question that I think you already answered by way of answering the other question, with someone who is on Ven-O and doing well, but they had problems with their IGHV mutational testing technically, just couldn't get a result, and whether it mattered. But I think you've answered that already, so we'll move on from there. I'm going to go to Irina. There was a question about monoclonal antibodies. And the question is, do you need to test positive for COVID in order to get access to the monoclonal antibody?
So the answer to that question is yes. So the testing, like I said, could be done either if you've had access to a rapid test at your home, or if you've had it in another scenario with a practitioner or a PCR testing. So again, just to repeat that criteria, my experience has been, since we've kind of been submitting forms to the WRHA for either the monoclonal antibody or the antiviral, the eligibility for patients that have been accepted have been those that are on active treatment. So whether they've been on ibrutinib, Venetoclax, or some kind of chemotherapy agent. We've had some people that have been approved that are on SCIG and are severely immunocompromised. And then some of the patients that, again, are not on therapy have been denied. So again, like I said, it's time sensitive. So normally they want to give you that treatment within 7 days of your symptoms presenting themselves, and within 7 days of having that positive test. So that's why if you do test positive, it's really important to get that information to us sooner than later.
And we move pretty fast once we get it. So yeah. Do you know, Irina, or anybody, if there's a CLL support group?
So the psychosocial oncology program has a lymphoproliferative support person that and sometimes group. I don't know if Kathleen has anything to add. Otherwise, the support groups are really through the national organizations and patient advocacy groups. So the CLL Canada is a patient advocacy group. They often partner with organizations such as Leukemia Lymphoma Society of Canada and Lymphoma Canada, which do have CLL specific patient groups and support groups that you can reach out to. But within cancer care, our psychosocial oncology group is very aware of our CLL patients and are a fabulous resource.
Kathleen, I have 3 more questions. Do we have time? Yes? Okay. So do you mind if I put you on the spot, Dr. Banerjee?
I will try my best.
I could probably answer a couple of these now that we've slowed down on the questions. I'll do the first one. It was somebody who said they were diagnosed with CLL later in life, and they wondered if CLL has been kind of lurking in the background all this time and then just kind of declared itself, or was there a trigger at some point that just switched the CLL on?
So that's a good question that I don't know that there is a true answer to, but the likelihood of people having the CLL for a while before they're diagnosed is likely a true phenomenon. These cells are present within your bone marrow, within your lymph nodes, within your spleen and your blood system naturally, and they have to basically go beyond the detection threshold before they're flagged as an abnormal result on that blood test or on the clinical examination. And so the reality of the situation is these cells are present and they're growing, and they've likely come from one cell that is now continuously dividing and growing and having an advantage. And it's not having a timed cell death, which is the typical scenario. Usually those blood cells last about 7 to 10 days in the blood, and then they're supposed to go away. And that's not happening. So it takes a certain threshold for you to cross to have that flagged. Now, the rate at which that happens is different for every individual. And that's where the staging system comes into play. So if you're in that low risk category, that burden of disease is lower. And as you get higher, that burden of disease is higher. And that's reflected in the bone marrow by the blood counts getting lower, or by the organs enlarging in the lymph nodes and the spleen. I do see that.
Oh, go ahead.
No, I was going to say the one question that sort of popped out with me is the longevity of CLL.
Yeah, 90-year-olds, right? That was my next one. Absolutely. And as we see more people living longer, we're lots of CLL patients in their 90s, and who we
can treat, who we have options for.
Yeah, and do very well, keeping their independence and living a good quality of life is what we're aiming for. So absolutely, yeah. Last question before we say goodbye then, is someone who said they were born without white blood cells, and they are a son of someone who recently was diagnosed CLL, and they want to know if they should be concerned, perhaps from worried that they may have inherited CLL, and plus they have an immunity issue because they have low white cell count. How does that integrate or change? It's tricky.
Yeah, I don't know that we can, honestly answer that question based on the fact that we don't have information to make all the right conclusions. It has not been my experience in 10 years of practice that there are individuals that have that were born with a genetic defect that led to that low white blood cell count, and a family member having a diagnosis of CLL. I think what's more common is someone having a diagnosis of CLL and other blood cancers in the family. But I do think that it's really important to understand that immune deficiency as a whole does predispose to cancer. And so it would be very important to have those conversations with your doctor so that you are monitored as per your family doctor or your specialist recommendations.
Great. I think that is, there's a quick reminder from Sarah that regarding the COVID and getting access to your monoclonal antibodies, she said that you have to remember to keep doing your rapid test, because if your first one is negative, you got to do it again in a day or so, because you have that short window to get your monoclonal antibody. So just a quick reminder that that is very true, because the sensitivities of these rapid tests.
I did want to mention that, Cancer Care is only open Monday to Friday, 9 to 5, and this is happening on the weekends and the evenings. Then the health links is where you would go to report that information so that you can get access in a timely way. And the other alternative, which is not often helpful, that people do try, is the hematologist on call, but they don't have the ability often to submit all the forms and get all that information. So my preference would be that people call to Health Links after hours.
Yeah, that's the instructions we're giving them. And Health Links has been great. They're very prompt and get everything in order so that you're not waiting the weekend to get this going on Monday. Great. So there's lots of thank yous. This is session is being recorded, and Kathleen will look after the logistics of that. And I just want to thank everybody who participated and who took the time to share their experiences, and to all the participants who came out and listened, and we really appreciate that as well. So I'm very, very happy and very pleased.
Yeah, thank you, Dr. Yang, very much for leading us in this discussion tonight. And it was really important for us to do this. It's been a long time, and people have been very disconnected. And this has been wonderful, having everybody together and the CLL community here, just being able to connect. So thank you all for joining. Thank you to the presenters. And I do want to invite people to take a few minutes to complete our evaluation, because it's important for us in planning future events. We really value your feedback. So thank you all, and have a good night. Take care.
Thank you.
Bye.